Hear the latest reporting and analysis on the big stories of the day on the Daybreak Insider podcast. It's top-notch reporting from SRN News, along with the sharpest insight from Hugh Hewitt, Mike Gallagher, Dennis Prager, Sebastian Gorka, and the voices of townhall.com. The Daybreak Insider podcast. It's your first look at today's top stories. Available at Apple Podcasts, Spotify, Google, and at SalemPodcastNetwork.com.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
You bet. And by the way, healthy legs are happy legs, and the happier you're going to be is when you get yourself taken care of. So welcome to the program. If you've not been with us before, Dr. Randall Juleff, the Medical Director of Vein Clinics of Hawaii, situated on 4 islands and bringing you the very latest in treatment. And what we do on this program is sort of point you out what this is all about. And since a lot of times, we do certain cases and we do, certain case studies. Today, we're going to talk about one of the big major problems to do with venous insufficiency. And that's where my medical, expertise starts and middles and ends. So it's time to talk to the doc. And today, we're going to talk about blood clots. And I know that might sound pretty yucky, and I guess it is in some respects pretty yucky. But if you have them, you need to get rid of them. Let's talk about that a little bit.
Yeah. Well, I usually like to talk about, deep venous thrombosis, and actually there's something called superficial venous thrombosis also. We're going to touch on that too. But March every year is what we call DVT Awareness Month, and DVT stands for deep venous thrombosis. It's, the common sort of blood clot that occurs in our legs. And even though it sounds like a simple thing, it can be extremely detrimental to not only your leg health, but your overall health, because, bad things can happen because of a blood clot forming in the legs, most notably something that we call pulmonary embolism. Which is when a piece of that blood clot breaks loose and travels, follows the venous bloodstream up through the heart and then out into the lungs. And that's what's referred when that blood then reaches the lungs, the circulation of the lungs. It can create some major problems, and that's what we call a pulmonary embolism, and something that can be fatal. So, we talk about DVT during March, and just kind of get people a little more aware of the entity, the thing that we call deep venous thrombosis, so that they can be aware of it, and probably most importantly, know whether they are at a high risk for developing something like DVT.
And that's what I like about the program, gang, because sometimes when you hear about this and then you look into it, it prevents a whole bunch of terrible stuff. I mean, and I do know that when we get around to talking about the deep ones, that when people think of the word blood clot, they think of, like, when I first learned, you get a little cut on your hand and it gets a scab over it, and that's a clot. Yeah. And I guess it is.
It is.
But in actual fact, these clots that we're talking about are monsters. that are hiding in your body.
They, they can be big. There's no question about that. When a clot forms, it takes up the entire space of the vein that it's in.
Yeah.
So if it's in a small vein, it'll be small, and it'll be less consequential, maybe inconsequential. But if it's in a large vein, there will be consequences for sure. So clots occur in veins. I mean, clots can occur anywhere, but the thing that we're talking about are clots that occurs in veins, and there's two systems of veins. There's what we call the superficial venous system, and then the deep venous system. And basically, those are good names because the superficial veins in our legs are more superficial. Deep system is more deep. The deep system is a little bigger, and it carries a fair amount more flow. Mm-hmm. It's about 80% of blood flow through veins in our legs go through that deep system. So those veins are bigger. If there's a problem with the deep veins, often the consequences are also larger. But superficial venous system are veins that are more superficial. Typically, we don't see them. They're not so superficial that we see them. So when people have superficial veins like varicose veins, spider veins, that kind of thing, they're not what we're talking about. They're a part of what we're talking about, but they're not the normal superficial venous system. And again, they're still a little deep to the skin. We don't really see them, but those are the two systems.
Yeah, and when you talk about, basically this is all over your body. But I do know that when we talk about legs,
right,
it's gravity. Mm-hmm. And then aren't there divisions within the legs? I mean, it's high leg, low leg, middle leg, all over.
Right, yeah. So we talk about the different levels because the consequences of a clot in a vein is going to be dependent on not only how big it is, but also where it is.
Yeah, how far away it is from the heart or brain or whatever.
Yeah, actually it has more to do with, again, the consequence. For instance, if we develop a blood clot in the large pelvic vein, you're affecting the entire blood,
everything,
blood return from the entire leg, as opposed to if you've got a clot, a smaller clot in the distal part of the leg. The distal is the below knee part of the leg. And that clot is going to be smaller because the vein is smaller, but also it's going to be less obstructive to the overall blood flow that's going through the venous system of the leg. So and then can arm veins develop blood clots? Yes, they can. They don't have the same magnitude of negative repercussions or consequence. Can they break loose and go to the heart and lungs? Yeah, they can, but it rarely happens. It's nowhere near the threat that a blood clot in the deep venous system. Usually, blood clots in the arms are more a product of some sort of external thing that was used. For instance, if somebody is in the hospital and they have an IV put in their arm, typically it's a superficial vein in the arm that's going into, and that might cause a blood clot to form. Or other, intravenous kind of devices. So arms typically are not, the kind of thing. Blood clots in the arms are not the things that we typically talk about when we talk about DVT.
Does everybody ask you what starts them? I mean, is it like a pearl in an oyster? 1 grain of sand, and then pretty soon it's a pearl.
Yeah. There are a set of things that can lead to. Or just increase the risk of developing a blood clot. And the probably the most common thing is a sedentary period that person is going through for one reason or another. We talk about being on airplanes all the time, and that is a perfect example of, you go onto a plane, you might sit on that plane for 6, 8, 10 hours. and you tend to not get up and around, and with that inactivity, and that even though it's a short period of time, that inactivity can cause lack of flow through veins. The blood gets a little sluggish, and that is one of the things that can kind of set you up for developing a blood clot. So, but not only airplanes, but long car rides, or anything like that, bus rides, train rides, etc.
One has to think, too, that maybe, and I know we're going to get a lot more involved in the program, but also there's a lot of people during this whole pandemic have been less active than they should.
Right.
They get into a habit, they get bored, they're sitting at home, and they end up binge watching TV all day.
Yeah.
And they're in a recliner, but they're sitting down all day long, and the only time they get up is to get something to eat or go to the bathroom.
Yeah, that would be another good example for sure. Yeah. And I'm sure that probably has happened. That scenario has occurred where people are at, or even for instance, illness. Illness.
Sure, been bed with the flu for 2 weeks.
Yeah, and it doesn't have to be in the hospital. You're ill at home, and you're laying in bed for most of each day. So that's another thing that's a risk or a risk factor for DVT. Dehydration, and that sort of goes along with illness too. When we're sick, we don't take as much in orally, and we're sedentary, and again, that's kind of a setup for DVT. People who go into the hospital. Virtually everybody who goes into the hospital is at risk for developing a DVT. Now, if you're older and you have multiple other medical problems, you're at a much higher risk.
I was just to say.
But if you're young and active and you're in the hospital for a short period of time, not so much. But this is something that we have as a medical community. Across the country, recognized a while back, maybe 10, 15 years ago, we finally recognized the fact that when people go into the hospital, there can be a very high incidence of DVT, and the medical system within this country got very more proactive with identifying that. And identifying the risk in individual people that are going into the hospital, and basically everybody nowadays gets put on some prophylactic medication that is going to protect them from deep venous thrombosis. And again, especially older age group, multiple medical problems, and it's so important. We've gotten very, very strict with those prophylactic maneuvers, and it's the benefits have been tremendous for sure.
I would imagine too, because of the pandemic and people spending a lot more time in hospitals. I mean, some of these folks that have been on ventilators or just in bed for weeks or months. Yeah. And look at how many people have just not gone to the hospitals for all kinds of things because they don't want to get in or be around that.
Sure. Yeah. So, and speaking of the pandemic, COVID in and of itself, the illness of COVID is, it creates a hypercoagulable kind of state. So, we're seeing a lot of, coagulation, clot problems in people with COVID. So, that's a whole different spectrum of issues. But, just in general, people going into the hospital, high risk, and especially those people having specific types of surgery. People who are going into the hospital for orthopedic surgery, if they're having like a hip replacement or a knee replacement. We just see statistically a very high level of DVT post-op in those patients.
Interestingly enough, just out of curiosity, and I do this Budinsky thing because I've had 2 hips replaced. And I'm also a patient of Dr. Juleff. I think, though, that the type of surgery that I had and the orthoscopic surgery with the hip replacement now, you're up the next day.
Yeah.
But I mean, back in the day when I did it, it was most people spent around a week in the hospital, several days anyway.
Right.
And I'm wondering if this is good, right?
It is good.
The quicker you get somebody up on the feet, the less they're going to have a chance of getting that blood clot.
Right, and which is one of the reasons why it has gone in that direction for sure. And I mean, not only hip replacement and other orthopedic surgical procedures, but all surgery. I mean, we've really gone to a very aggressive format of getting people up and around after their surgery, as opposed to 20, 30 years ago when you'd lay around the hospital or lay around in the hospital for 2 or 3 weeks.
Which brings us back to this square one. With venous insufficiency, and what Doc is talking about, because I can remember when my mother many years ago had vein strips. She was in the hospital for a week, and today, I mean, I'm in your office for an hour to get the same treatment that somebody used to get in the hospital for being in there several days. Yeah. So that's and one of the things that I think it's the day and night difference between the way your profession has grown over the last 30 years with regards to that exact thing, getting people in there and out of there.
Right. Yeah, exactly. Unfortunately, a lot of good things happen in hospitals, but unfortunately, a lot of bad things can also happen. But surgery of any orthopedic surgeon. Neurosurgery is another one where we see a very high incidence of DVT, and then also any operation that takes place in the pelvis. So a lot of, like hysterectomy and anything that, takes place in that area, people have a much higher incidence of DVT, and we have to protect them against that. Malignancy, just in general, when you have cancer, you have an intrinsic hypercoagulable state that's happening.
Of course, yeah.
And so those people are at a higher risk. So when somebody with a malignancy comes into the hospital and becomes sedentary, the risks sort of pile up on each other. So we have to be very aware of all of that. There are congenital or inherited hypercoagulable states. So there are genetically, produced hypercoagulable states that it alters the coagulation system, and people are more prone to developing DVT. So there's that. Other things: trauma, injury, obesity. Of course, we know about obesity not only affecting venous and arterial problems, but especially DVT. Pregnancy is another thing that has a higher risk of DVT, and then a whole host of other medical problems. Some medications may put you at a higher risk of DVT, and probably the prime example of that is birth control pills. So you always have to be concerned about that, especially if you are involved in an activity that in another activity that puts you at a higher risk for DVT. For instance, smoking.
Yeah, I should say there's all these other things that have harsh consequences if you do them.
Yeah. So, and then in some people, there's no apparent cause whatsoever.
Yeah.
We just don't know why they developed a DVT, but they did. After we diagnose it, and we refer to those people as having a DVT that was unprovoked. And those people that have what we call an unprovoked DVT, we get a little more concerned about those people because
you don't see it coming, right? I mean, they haven't caused it. They don't think.
Well, yeah. The questions then arise, the question that arises is there something going on with this patient that we don't know about that is the cause, but we just don't recognize it in that patient? And probably the two most concerning things are: does this patient have a malignancy that we don't know about? So often if somebody comes in with an unprovoked DVT, we do a little investigation, and we start questioning. Gee, maybe they have. Do they have lung cancer, or do they have, an abdominal malignancy, something like that? So you have to, raise all these questions. when somebody comes in with a DVT that there's no apparent reason for it. And then also, like I mentioned, these genetic thrombophilias, these hypercoagulable states based on genetic abnormalities. And that's another thing that, if somebody has an unprovoked DVT, we often test those people.
I was going to ask you that. People go into hospitals, different things, trauma, whatever, all the things we talked about.
Yeah.
But would there also be, every now and again, a reason, specifically if it's a patient of yours or, some with venous insufficiency, is be tested when they're in the hospital. Have somebody do an ultrasound on them right when they're there to just make sure that they're okay.
There might be situations like that. Usually we're guided by symptoms, but you bring up a little more interesting point, and that is that people with venous insufficiency, they are also at an increased risk of developing DVT just by virtue of the fact that they have venous insufficiency. And there's a whole heck of a lot of people out there that have vein problems and they don't know it because they haven't.
I'm glad you brought that up because I talked to so many people that listen to our shows, and one of the concerns they have is, I didn't see it coming. And one of the things that I hope, by the way, some of you have learned, and you can go to veinclinicsofhawaii.com and listen to previous shows and look at some of these things, in that it's an inherited deal. It's also a very cruel disease because it takes a long time. Something's going on in there and percolating around in your body that you have no idea is going on until you get symptomatic, which might be 20 years later.
Right.
I think that's one of the most fascinating things I've learned.
Yeah. Well, it takes, just by virtue of, the history of venous insufficiency, when somebody finally does become symptomatic and comes in, they've already had it for years, for sure. But anyway, so let's talk about, we talked about the fact that there's superficial veins and there are deep veins. Blood clot can form in either one of them. So let's talk about the superficial ones first. We call this superficial venous thrombosis as opposed to deep venous thrombosis. SVT is how we refer to it. And often the layman's term for superficial venous thrombosis often is phlebitis. You may hear people saying, "Oh, I had a little bout of phlebitis," but it's not an uncommon thing. 125,000 people in the U.S. suffer from a SVT yearly. It affects women a little bit more than men, probably not a lot, but a little bit more. And it's the most common feature, especially if we're talking about SVT in the legs, of course, is that it happens in somebody who has varicose veins, and typically. And why does that happen? Well, it happens because of the fact that, as varicose veins form, these are branches off of the superficial venous system. They're very tortuous. The blood does not flow normally through varicose veins. It can become very sluggish. And when the blood becomes sluggish, that's one of those things that can lead to blood clot formation. And so if it happens in a varicose vein, that would be referred to as a superficial venous thrombosis. So often it's SVT is seen in people with varicose veins. Often trauma will incite the occurrence of a venous superficial vein thrombosis.
When you say trauma, you mean like banging it, being hit?
Right, being hit or hitting your leg against something or whatever. SVT is usually a fair bit less concerning than deep venous thrombosis. There are situations which would call for more concern, and that is if the clot within a superficial vein is very extensive. The superficial venous system in our legs empty into or flow into the deep venous system. So
which are bigger pipes.
Which are bigger. And if the blood clot in that superficial vein is getting too close to the deep vein, then we get a little more concerned because that superficial vein may extend then into the deep venous system, and that's kind of converting an SVT to a deep venous thrombosis, which is something that we don't want. Some people will have recurrent SVT or recurrent episodes of phlebitis. And when we hear that, we also get a little more concerned because we ask ourselves, gee, is there a reason why this person is having repetitive episodes of thrombosis of any kind, whether it's deep or superficial?
I was going to ask you that because I remember at previous shows that unfortunately when you've had that, now it's another thing you have to keep an eye on because you if you have the propensity to have one, who knows if you're not going to have more. I mean, you can fix the one that's there,
sure,
but whatever caused that one get bad, maybe that other part of your leg going to get bad too.
Yeah. Well, and more importantly, is there some underlying process going on that is causative? You know, for instance, when we see people with recurrent SVT or recurrent episodes of phlebitis, we wonder, do they have a malignancy that we don't know about?
Of course.
Or do they have a hypercoagulable, situation going on that we don't know about? And should that be treated? You know, so those are all things that run through our minds when we see repetitive episodes of either type, SVT or DVT. So if somebody has an episode of superficial venous thrombosis, what does that look like? Well, you know, usually it's red, it's inflamed, it's warm, it's tender. You know, people.
Yeah, now that can be a patch of skin you're talking about, right?
Yeah, right. We're talking about superficially.
Right.
An area on the leg, or the same thing would go for the arm, but we're talking more about legs. And often it's in an area where the patient again previously had varicose veins, but you can't see the varicose veins because of this, edematous, swollen, red, inflamed kind of area. It's not an infection. It's just inflammation.
I'm going to guess though that a lot of people think, "Oh, I got that infected.
Yeah,
I'll just rub some cream on it. I'll be okay."
Right. Well, a lot of people, might think that it's an infection, and even go to the emergency room or urgent care, and they may be treated as if they have an infection with antibiotics, but that's not really getting to the crux of the problem. People might even have a low-grade fever, but again, it doesn't. It's not an infection. It's just inflammation, and it can result in infection. If, for instance, in the situation that I talked about before, with arm phlebitis, SVT of the arm, if the person had a previous IV or something inserted into that vein, then it can become, it may have been contaminated with that IV and catheter, and then that might result into an infection.
It's interesting you say that because every now and again we touch on this, but there's a lot of people that that are addicted to drugs or drug users, and they keep telling you, you can get free needles, you can get needle exchange, this and that. Talk about that very danger of somebody that's injecting themselves with something.
Oh yes,
I mean, whatever you're putting in there, you're also putting other stuff in there that may be a lot worse for you.
Oh yeah. And I mean, not only phlebitis, but also bacterial infections that can affect the heart and other parts of the body. So how do we treat SVT? Well, we don't have to get real aggressive with it, but there is a way to treat it in order to limit the process and limit the symptoms, because like I said, people come in and the leg can be pretty tender. I'm always impressed by how uncomfortable some of these things can be. So we start them immediately on an anti-inflammatory medication like Advil or Motrin or one of those. We usually recommend that they do warm, moist compresses. That again just kind of helps from a symptomatic standpoint.
Is that mostly to feel okay?
Yeah, it's not. A warm, moist compress is not going to do anything to make the process resolve any quicker, but it's going to help the symptoms a little bit. And then, of course, our ever-present compression stocking.
I was going to say, here comes compression stocking alert.
Yeah. So that helps too. It helps again with the symptoms probably more than anything, but it also helps with the fact that, this person often, again, when the SVT occurs in the leg, that's occurring because of varicose veins, and which is a part of venous insufficiency, and those compression stockings are going to help that situation and hopefully help the symptoms that might be related to venous insufficiency, but also limit further, coagulation in other varicose veins that patient may have. So, again, compression stockings are always a good thing.
Yeah, and by the way, just a total aside, gang, and these compression stockings are part of my life. And I got to tell you something funny that happened 2 weeks ago. And I don't know, I should have called you, but I didn't. And here's what happened. I put on a pair of beige compression socks because I was going to wear beige pants. And then I decided, no, I'm going to wear something else. And so instead of taking the beige ones off, I put the dark ones on over the top of the beige ones.
Yeah.
Now I have two. I just wanted to try it.
Sure.
And it is amazingly different.
Yeah.
I mean, it's a lot more compression.
Right.
Yeah.
Yeah, it would be. I don't know if it's completely additive, but there is more compression for sure.
Yeah. And which tells you that, a little is good, a lot is better, but then there also is a point where it's maybe too much. Like you don't want to keep them on for 24 hours or sleep in them, do you?
Yeah, probably not.
Yeah.
Probably not. But that's interesting. I don't know that I've ever had anybody tell me that. So I'm glad you did that little experiment.
I just did it once. I'll confess.
Yeah.
But I thought to myself, if it doesn't feel good, I'm just going to take them off.
Yeah, sure.
But it felt fine.
Yeah. Well, good.
I tell you one thing: it's an awful lot putting them on. It's easier. Even though you've already got a sock on, that other one glides right over the top of that.
Oh, it's easier to put the second one on.
Much,
yeah. I would think.
Yeah.
Well, that's good to know.
Hey, if you don't believe me, gang, you wear compression socks out there. Try it. Just put on a second pair, see what it feels like.
I'm going to start recommending that to my patients, Mike. Yeah.
There you go.
I'm going to call it the buck method.
The double buck method. Yeah, there you go.
So that's the usual way that we treat it. Now, when somebody comes in with SVT, they are at, like I mentioned, they're a little higher risk of also having a DVT.
Gotcha.
So,
no guarantee, but high probability, I would imagine.
Well, they're not high, but not a high probability, but there is some, chance that they might. So, people that come in, and, this is something that people should also know. If you develop an area that you think is phlebitis, can you treat it at home alone? Yes, you can. Will it resolve? Yes, it will. But it's something that you probably should come in and have us take a look at, because one of the important things that we do when somebody comes in with an acute SVT is we do an ultrasound to make sure that their deep system looks fine. And DVT happens frequently enough to warrant that.
Yeah.
We really do need to make sure that they don't have a deep venous thrombosis.
I kind of think that some of the shows that we see and some of the ads on TV at night are really helpful in that area.
Oh, yeah.
They really call, I don't know, that may be me. VeinClinicsOfHawaii.com. It's worth it. I mean, listen, it's just like anything else, isn't it? There's any number of doctors that will refer somebody to you, and the same thing might happen that you might refer somebody to a dermatologist. I mean, there are lots of referrals within your business that deal with these cases because of the symptoms that they manifest.
Right, right. So in addition to those things, I mentioned that some superficial clots might be a little more threatening, especially those that are getting very close to the deep system. And in those patients, on rare instances, we also put them on an anticoagulant. And again, because we don't want that clot extending into the deep venous system also. And if, like I mentioned before, if somebody has had recurrent SVT, then we may want to do other things, other investigational kind of things to make sure that they don't have a malignancy or some kind of genetic disorder. If varicose veins are a part of the picture, which they often are, like I mentioned, then typically we're going to do a full evaluation of the venous system. and make sure that they don't have chronic venous insufficiency or venous reflux, which again they often do. And if they had varicose veins in the area of their SVT, then 99% of the time they are going to have chronic venous insufficiency. And we don't do we treat that? Yeah, we treat that not immediately. We let them kind of resolve their SVT, and then 4 to 6 months down the line, we then do the procedural things to fix their superficial venous insufficiency, because we don't want them developing another SVT in the future.
Good.
Okay, so on to deep venous thrombosis. So, again, DVT is much more serious than SVT, and it really requires a much more aggressive treatment plan. Early recognition and early treatment is definitely the way to go. And that's why we talk about this stuff, and that's why we've designated March as DVT awareness, because if you have the symptoms that we're going to talk about, you really do need to have it looked at. You can't be too careful with something that is potentially fatal, and DVT blood clot can be fatal. So, and the threat is, again, pulmonary embolism.
It's, by the way, gang, it's one of the few things that we talk about on a regular basis that are terminal. This is way more dangerous than a lot of the things you treat. A lot of the other things are symptomatic, pain, suffering, swelling, blah, 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 but not life-threatening, just lifestyle-threatening.
Yeah.
This stuff is life-threatening.
This is life-threatening. Yeah, exactly. And then the other thing that happens, not only pulmonary embolism, but the other serious thing that can happen is that when you develop a blood clot in the deep venous system, most of the time it's going to affect the function of that deep vein in one way or another. And if you're not treated fully and aggressively for the DVT, then you can end up with very long-lasting detrimental effects to the deep venous system, and the function becomes very, very, very poor. You develop reflux in that vein, and that can lead to further major problems down the line. And we'll talk about that a little more later in the show. So, so there's something called Vercause Triad, and Vercause was a old German physician. I think he was a pathologist, but anyway, so he came up with 3 things that happen, 3 things that are part of the picture of a blood clot forming. One of them is sluggish flow of blood through the vein, which we've touched on already. The other thing that happens is an internal injury to the inner lining of the vein. And you can imagine if you have an injury to the inner lining of a vein, then it's going to be more likely that because of the chemical and molecular things that happen, there's a more likelihood that blood is going to clot. And then the third part of this triad is, again, hypercoagulability. And there's all sorts of things that we already mentioned that might make a person be hypercoagulable. So those are the things. So if, for instance, let's get this into the real world kind of thing. If you're hypercoagulable, let's say you're pregnant. Or let's say you do have a malignancy that you know of. Or let's say you have heart disease. Heart disease is a medical issue that is in some ways going to make you more hypercoagulable. And you you jump on a plane, and you're going to be on a plane for 8 hours, and it goes without saying that inactivity is going to lead to sluggish blood flow through your veins. Again, those are the types of things that's the setup for developing a DVT, and that's really what goes where what this triad kind of goes to. So there's for each one of those categories, there's a whole host of different things that may result in each of those categories. So the extent of symptoms of a DVT is really dependent on the level of the clot. For a very low clot, and by that I mean in the lower part of the leg, if you have a clot in the part of the leg that's below the knee, you may have minimal symptoms. You may not even know that you have it. You may be completely asymptomatic, or you may have just, mild kind of symptoms that you're not going to pay attention to. And we see this periodically. When we do ultrasounds on people, we see evidence of a patient having a DVT in the past that they didn't even know about. Sometimes it can be very extensive, but especially in the lower leg. So the higher the blood clot, and by that we mean, the thigh, upper thigh, and also the pelvis, the more symptoms you're going to have, and basically that's kind of intuitive because the higher the clot, the bigger the vein, the greater amount of the circulation that you're
that's been impacted. Sure, yeah.
So it's kind of like a blockage on the H1 compared to some side road. So the bigger the vein, the more symptoms that you're going to have, and the more likely that you're going to have longer lasting symptoms and potentially longer lasting problems. The
with
secondary
that,
problems.
Yeah, and it seems to me that some of that could be severe.
Oh yeah,
Yeah.
absolutely. Yeah, when clots affect big, higher veins, and it has a long lasting detrimental effect to the function of those veins. Yeah, the circulation of that leg will very likely will never be the same. It will never be normal again. Yeah. And
which, by the way, is a huge threat to your lifestyle. I mean, some of these things, Doc, you can make walking uncomfortable. So that you don't get motivated. Maybe you used to ride a bicycle. Maybe your legs are too sore to ride your bike. Yeah. So, I mean, you give a lot of lifestyle up by not monitoring this.
Right. So, again, early recognition and, aggressive early treatment. I mean, that's the key to all this stuff. So what are the usual symptoms? Well, somebody has a DVT in their leg, and basically the two main things are pain and swelling.
Yeah.
Again, the higher the blood clot, the more swelling in particular that you're going to have. There may be a little bit of redness that people see, and that's primarily, usually in the, below knee part of our leg, on the calf or whatever. But however, it's not really intensely inflamed and red and tender the way it is with a superficial venous thrombosis. The patient might have a low-grade fever and a blood clot in our circulatory system, causes that. So, but again, it's not infection. It's just this blood clot. There's something called Homan Sign, and that's one of the things that we're taught in medical school as being a fairly reliable sign of blood clot. And what that means is that when you flex the foot upward, when you're tightening the calf muscle by doing that, you get a fairly intense pain in the calf muscle.
Yeah. Like crampish feeling?
Yeah, well, crampy or just a throbby kind of pain. And that's something that we call Homan Sign. There's a number of different ones, but that's the main one that we're taught in medical school, and that's something that you can if you realize that and if you recognize that as a potential symptom for people at home, they can use that. The final diagnosis, of course, always is definitively made by ultrasound these days. It used to be a fair bit more difficult in the past to diagnose DVT when we had to rely on, shooting dye into veins and following it with X-ray and all that sort of stuff. But
that's what I said earlier. You come a long way in what's going on, particularly the ultrasound, and I see more and more of it. I mean, now it's in every room, every hospital you go to, every ER. Everybody's got some access to ultrasound for different applications.
Yeah.
And there's all kinds of machines, right?
Oh yeah. There's all kinds of machines, and they're little different. We use these probes that are attached to the machine, and there's a whole host of different probes for what exactly you're looking for and how far away it is from the probe, and the ultrasound has become a spectacular tool that we use every day of the week.
And and maybe comment to that too, because I've met many of your folks. Not just the machine, but the operator. I mean, some of these folks, I mean, don't they get extremely capable at being able to give you the info that you need?
Yeah, well, when we work together for a long time, it is very much like that. And they know the information that we need to define. And you're right. I mean, good ultrasound techs are very hard to find. They have a very special talent. And luckily, we have several very good ones. So, and we rely on them heavily for sure. So the ultrasound is really going to. It's a pretty easy technique to show DVT below the level of the groin with the ultrasound. That's a pretty easy thing to do. Sometimes, however, a patient might have a blood clot that extends above the level of the groin. Those blood clots.
Then what?
Then what? For that we have to do a little different exam, and usually it's either a CT scan or an MRI. Okay. And both of those can be done in a way that we use some contrast. And we can define, where the clot is, and sometimes it goes, it can go quite high, depending on, the clinical scenario and that kind of thing. So, sometimes we need a little help in addition to ultrasound to completely define it. So what are the complications of DVT? We've talked about a few of them already, but the two main ones we've mentioned are pulmonary embolism, and then also something that we call post-thrombotic syndrome, and that's that situation where the blood clot is very detrimental to the continued function of that deep vein, and it can create problems in the future. But and we'll talk about that a little bit more here in a minute. But so pulmonary embolism, like we mentioned, you develop a blood clot typically in the leg or the pelvis. A bit of that clot breaks off, or sometimes a big part of that. And
now it's a traveler, right?
Yeah,
it's going
now it's traveling. It's traveling north, and it goes through the larger veins. The largest vein in the body is called the vena cava. It goes through the middle of the body and up to the heart. So these clots can break loose, follow the blood flow, and they don't create a problem in the heart. It's not like they're going to. They don't stop in the heart.
I was going to say they just go right through.
Yeah, they go right through, and then they get pumped into the pulmonary circulation. The circulation going to the lungs, and what happens? Well, what happens is that whatever part of the lung that blood clot has now affected the blood flow to is no longer functional with respect to getting oxygen back into the blood. So and if that blood clot is obstructing the blood, the pulmonary circulation, the blood flow to the lungs to a large extent, again, it can be immediately fatal. I mean, people all the time, people fall over dead from PE, and we probably don't even know exactly how many people are out there that happens to, because so many people die suddenly and we don't do autopsies or whatever, and so it's we have a rough idea, but all of the numbers that we have are probably underestimated.
It's interesting also when we talk about the pandemic, that aren't we learning a lot of things about the pandemic? People don't understand that it's a respiratory problem. Yeah. I mean, and so when you're talking about your heart and your lungs and And it's all together. It's all in one place.
Oh yeah.
Yeah. So all these other,
related.
all the other, when they talk about somebody dying of COVID, they had underlying conditions. A lot of those are what we were discussing.
Sure.
Yeah.
Right. Exactly. So how often, if you look at all those people with deep venous thrombosis, how often does PE happen? Well, it's estimated to be about 10%, but again, that number is probably a fair bit larger because, there's probably a good number of people who have a small amount of clot that breaks off, goes to the lung, and they don't have any major consequence from it. But again, the rough number is about 10% of people with DVT. Pulmonary embolism, as we mentioned, can be fatal. The more likely the pulmonary embolism is going to happen to a greater extent in those DVTs that are higher in our body, the upper leg and the pelvis. Those are the clots that are more likely to break off and go to the lungs. 1 million people are affected in the U.S. annually by pulmonary embolism. 100 to 200,000 deaths occur per year in this country because of pulmonary embolism. And again, those numbers might be low. So a lot of people die over the course of a year from PE, and over half of those people are in hospitalized patients. So that just kind of shows you how much higher the risk is for people that are going into the hospital for several different reasons, for them to develop pulmonary embolism. Again, it can be a very it can be a fatal problem. So this other thing, the other major complication to deep venous thrombosis is the thing that I mentioned before, post-thrombotic syndrome, and that just refers to the abnormalities that the leg will ultimately go through over a long period of time, over years, as the function of those deeper veins deteriorates because of the clot. So, what is the clot doing? Well, the clot is, the clot forms in a large leg vein, and it immediately obstructs flow. So there's that, and there is swelling, but the body compensates for that. So, the clot forms, and then over months and years, if that vein remains completely occluded, then the blood's got to get around it somehow, and we form what we call collateral, channels. Collateral blood flow, which just means that rather than taking the highway, the blood is going to get off and go through secondary roads, and then make it back to the highway at some point thereafter. So that happens. However, over a good number of months, typically a good amount of that clot will resolve. Our body, even though the blood thinners don't dissolve the clot, the blood thinners really are just making sure that the blood clot doesn't get worse.
I was going to say, it can get around the clot, so it's a little bit thinner, so it can squeeze through those.
Well, it helps in that way, too. But invariably, most of the time, some amount of clot is going to, remain in a, fibrotic sort of way, plastered against basically the wall of the vein. And what's happening there is that the valves, the valves that are so very important in the blood flow through veins, those valves are being destroyed or damaged to the extent that they are no longer functional.
Yeah,
and
open them up.
And basically, the patient develops venous reflux in the larger veins of the leg, the deep veins. So what happens is that there's downward flow, and there's an increase in the pressure. We call venous hypertension. And so what happens ultimately are all those things that we talk about in those higher clinical levels of, venous insufficiency, with unremitting swelling, discoloration of the skin, the skin becomes thickened and fibrotic. We call that lipodermatosclerosis. And ultimately that can lead to chronic ulceration, basically, which is the highest, clinical order. And it's something that we don't want, that patient to get to. So we treat DVT with anticoagulation, and typically, again, depending on what the cause of that DVT was, will sort of determine the length of time that you would treat it. And then also getting those people in compression stockings, because it's so very, very important for their long-term vein and leg health to get them in stockings and keep them in stockings as long as they need to. And that's about it. So sometimes we get a little more aggressive with DVT, and we might infuse a medication that is referred to as a thrombolytic to try to actively break it down and dissolve the clot. But there's a little bit of controversy as to when that is best utilized. But everybody needs anticoagulation and compression.
Yeah, and I can tell you one thing that I've learned, and I'm sure Doc agrees, and that is that the more you become, willing to have it looked at, the better. And that's why we want to refer you to veinclinicsofhawaii.com, to get that, because this and a lot of other things are discussed there. Previous shows, some case studies, and a lot of other things. But the types of blood clot that you learned about today, superficial and deep, are they related? Maybe they are. Maybe if you've had one, you have the other. In any case, it'd be a good idea to get it looked at. And thank you so much for spending some time with us this time. We'll see you next time. From Vein Clinics of Hawaii, Dr. Juleff and all the staff, and me, Mike Buck. Thanks for listening. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.
Let me be straight with you. This is a radio commercial for 3 Small Business Insurance. The policy has no fine print. It's clear what's covered. So while you can't see the following scene, just know that this pet store is protected by 3.
Joe, did you leave the snake tank open?
Look, I don't want to point fingers, but yes.
It's biting me! Sorry, sir! I'm calling my lawyer.
They're going to need some help with this mess. Luckily, they have 3. No fine print, just exceptional coverage. 3 is a product of Berkshire Hathaway Direct Insurance Company. 3. No nonsense, just common sense.